हेलो एंड गुड इवनिंग एवरीवन। नया मॉलिक्यूल आया है जैसे आप सभी जान रहे हैं dapagliflozin और sitagliptin का। So the presentation topic is metabolic derangements in type 2 diabetes mellitus, and basically we'll see the how the incretin system in body really works and what exactly are the different metabolic derangements in diabetes. So this is a well-known slides. You are very well aware. This is the octet hypothesis of development of diabetes, where there is not only decrease in insulin and insulin resistance, and apart from these two pathophysiological mechanisms, there is also some other derangements, like there is decreased incretin effect. We'll see in further slides what is incretin effect. That is very, very important. And there is increased glucose reabsorption as well, because there is upgradation of SGLT2 receptor in these patient subset. So what exactly is the incretin effect? So this is really, really very, very important concept to understand in diabetes. So in the first graph, you can see the subjects were given oral glucose or IV glucose, and they have seen that the blood glucose levels were very identical. So if you are taking some meal in form of glucose or given the IV glucose form, the glucose levels are not changing as expected. So what exactly is happening in these group of patients, that oral glucose administration leads to greater stimulation of insulin response, and that is up to the extent of 50 to 70% than does the IV administration despite identical blood glucose levels. Here you can appreciate that the rate of insulin secretion, rate of insulin secretion with oral glucose is also more rapid compared to the IV administration. So here comes the role of incretin hormones. The incretin effect is caused basically by two hormones released from the intestine as a response to oral glucose, the GLP-1 hormone and the GIP hormone. GLP-1 is glucagon-like peptide, GIP is glucose-dependent insulinotropic polypeptide. So here you can observe that when the patient have taken oral or IV glucose administration, here you can appreciate that the secretion of GLP-1 hormone is higher with oral glucose versus IV glucose. And similar trend you can see with the GIP hormone. When the patient is given oral glucose, the rate of secretion of GIP is much more as compared to the IV hormone. So these are the two major incretin hormones. What happens when you eat something? There is some stimulation of incretin hormones from the gut. These are GLP-1 and GIP. The GLP-1 is produced from the small and large intestine, mainly by the L cells, but they are degraded by the DPP-4 enzyme. And similar trends is being seen with the GIP. They are only secreted from the small intestine, and they are mainly secreted from the K cells in the small intestine. They are also degraded by the DPP-4 enzymes. So here you can, this is the pictorial diagram how the incretins really work, how they affect the insulin and glucagon release. So here you can see that once you have taken something, there is a release of GLP-1 and GIP from the intestine. At the same time, you can see these hormones are degraded by the DPP-4 enzyme. Those who are reaching up to the pancreas, they act on the alpha cells like GLP-1, and they increase the release of insulin and thereby increasing the glucose uptake in the skeletal muscle, and this is the mechanism by which they decrease the blood glucose levels. And here similarly, this is happening with the GIP, which is acting on alpha cells, which is decreasing the glucose levels. And here you can see that this is degraded by the DPP-4 enzyme. So here you can see that GIP is working to decrease the glucagon release, so thereby decreasing the hepatic glucose output and further reducing the blood glucose levels. But the problem with the GLP, the physiological GLP and GIP is that they are degraded by the DPP-4 enzyme. The DPP-4 enzyme is found in the endothelial cells and intestine, liver and kidney cells. which converts the GLP-1 and GIP into inactive form. So effect of incretin hormones on blood glucose levels after meals. So this is all I have discussed, that the beta cells and alpha cells, how the GLP and GIP are affecting these things. So what happens in diabetic patient, if you compare with the healthy individuals, the incretin effect basically is decreased in diabetic patients. There is less insulin secretion despite oral glucose administration as compared to the healthy volunteers. And this is the extent of lowering of incretin effect. Here you can observe that those who are healthy, they are having good incretin effect, and once they develop the diabetes, they are having very decreased incretin effect. So there is less incretin hormones to have the decreased insulin levels. So this is one study which they have shown, and they have proven that this is really working in diabetic patients as well. So there are basically two strategies to improve the incretin effect in diabetes mellitus. Either you inhibit the DPP-4 enzymes, or you can give the GLP-1 receptor agonist. So we'll see what is the difference between these two options. So these are the other various effects of incretin hormones. They also basically act on the GI. They slows the gastric emptying, promotes weight loss. On others, they decrease the lipolysis. They have shown some cardioprotective effect. There is increased insulin secretion. There is decreased glucagon release. So this is basically, you can see the GLP-1 and DPP-4 inhibitor versus GLP-1 receptor agonist effect. Here you can observe when you give the DPP-4 inhibitor, so this is the increasing plasma GLP-1 concentration with the DPP-4 inhibitors, and this is the graph showing the maximum effect with the GLP-1 receptor agonist. So, but what happens with this much of peak, you develop some nausea, vomiting. There is definite effects on weight loss, but with DPP-4 inhibitors, you don't see these effects because of less stimulation of GLP hormones. So this is the one difference between DPP-4 and GLP-1 receptor antagonist. GLP-1 has clearly shown some cardiovascular benefit. They have shown to be better in terms of reducing the body weight, but they are associated with major side effects, what you are not going to see with the DPP-4 inhibitors. They are very neutral in CVOT, they are very less side effects, and they are less costly as well. So this is the summary action of DPP-4 inhibitors. So these are the available DPP-4 inhibitors. The most preferred for the cardiovascular safety, the sitagliptin is a better drug. Also, in those who are having CKD, the linagliptin is the preferred molecule. So this is one another slide which is showing how the SGLT2 receptors behave. So once you are taking some glucose, there is complete renal filtration of this glucose, but they are all getting reabsorbed and hardly any glucose is appearing in the urine. So these are the two receptors. Basically, SGLT2 receptors are being present in the S1 segment of proximal tubule, and they almost filter all the glucose, reabsorb. They act in reabsorption of all the glucose and return into circulation. And this is SGLT1 receptor, which is present in S3 segment, and they do the 10% of remaining job. So what happens in diabetic patient? There is upregulation of SGLT2 receptors, and here you can see because of upregulation there is increased glucose levels. And what you do when you give some SGLT2 inhibitors, these drugs block the reuptake of glucose in tubules and allow urinary loss of glucose. So this is all. Thank you so much. Thank you.
Thank you, sir.
So this is just a formality presentation on behalf of Sun Pharma. So I really very heartfelt thanks to Sun Pharma for their generous contribution for this CME of Indian Medical Association. Thank you so much.